our keynote speaker, Fabrizio Benedetti. Fabrizio is a professor of physiology and neuroscience at the University of Turin Medical School in Turin, Italy, and the leading researcher in the world in the field of placebo and nocebo studies in pain. Professor Benedetti has written multiple book chapters, and his research is published in many leading scientific journals where he's been highly and frequently cited. He's had a huge influence on all our understanding and practice, persuading me and many others of the importance of the understanding of the field of placebo and the importance of our specific words and actions in patient interactions. I first met him in the 90s, and he's won numerous academic awards from worldwide institutions in his career. Fabrizio comes from Turin, and Turin, I think, is the Italian Liverpool. You have a wonderful football team, Juventus, and of course Liverpool are playing tonight, which has put the kibosh on things. And Liverpool have a wonderful history in Europe, and so do Juventus. And I know that our games with Juventus are always friendly. The fans of both sides have huge respect for each other, because Turin is a northern city away from the glamour of Rome, just as Liverpool is a northern city away from the glamour of London. And whenever I met anyone in Europe, they always said, "Oh, which hospital in London do you work in?" I was always delighted to say, "No, never go near the place. I work in Liverpool." And I'm sure, Fabrizio, you get this. Where in Rome are you? And you're very pleased to say that you actually trained in Turin. You actually made your career in Turin, and you've remained there with a few trips to America. I know you've worked in Los Angeles and Dallas, and you're still associated with Harvard University. But I think one of the things that I respect Fabrizio so much for is he's trained and raised many young researchers who spread his legacy with further important scientific contributions, because there's so much to learn about this field. He's regularly interviewed on podcasts for comments on his research into the psychosocial factors that can generate illness. He speaks, of course, fluently in Italian and English and other languages. So, Fabrizio, tonight, we'd like you to tell us about the importance of the placebo effect. Thank you very much for coming.
Thank you very much for the presentation. Thank you very much for the invitation. Well, actually, in Turin, there are two football teams. One is Juventus, the other one is Torino. Juventus is much stronger, actually, than Torino, but I'm not a football fan, so I'm not very much interested in football, in soccer in general. So again, thank you very much. It's really a pleasure for me to be here, to join your foundation, Pain Relief Foundation in Liverpool. And actually, what I would like to do today is to give you a very, very general idea what we know about the psychological and the biological mechanism of the placebo effect. The placebo effect is really a fascinating topic, because we can study different brain functions. As a neuroscientist, I am both a basic and a clinical neuroscientist, so I'm pretty much interested in how our brain works. I use the placebo effect as a model. Well, actually, placebo effect is an excellent model to understand how our brain works. So I would like to give you a very general idea of what is going on in the brain of patients when you give a placebo, when the patient interacts with the therapist, with doctors, with nurses, with psychologists, in general with therapists. You will see that it is quite interesting. Well, let me share the screen, and let me see here. Okay, can you see it? Okay, so the title of my talk is Placebo and Nocebo Effects. Actually, these two effects go in opposite directions. And this is the overview of my talk and some learning objectives. And I would like to, first of all, to define a placebo, because there is a lot of confusion. And actually, there is a misconception about the word placebo on the one hand, and placebo effect or placebo response on the other. Then the second part will be about some similarities between drugs we give in routine medical practice and placebos. Actually, this is what is emerging today from a neuroscientific and neurobiological point of view. Drugs and placebos use the very same mechanism, the very same biological mechanism. Some examples, the opioid system, the endocannabinoids, the cyclooxygenase pathway. I will talk about pain, of course, but we know pretty much about the placebo effect in other medical conditions as well, like, for example, like Parkinson's disease or more in general motor disorders. I have no time, of course, to discuss these medical conditions. So I will draw your attention on pain, of course. Then I will say something about the nocebo. Let me use the laser pointer here. Can you see the laser pointer? Great. The nocebo effect and some clinical implications, what is emerging today from a clinical point of view, and why we can exploit sometimes the placebo effect in routine medical practice and routine clinical practice. So let me start with the very definition of placebo. And actually, there is a difference between the two words, placebo response and placebo effect. You see here that when you give a placebo, you can see an improvement, a clinical improvement, for example, reduction in pain. Well, this can be due to plenty of factors, like, for example, spontaneous remission, regression to the mean, which is due to selection bias in clinical trials, some detection ambiguity of a symptom like pain, and some psychosocial, psychobiological factors like the patient's expectations, learning. You will see learning is really very important. So the placebo response includes all these factors. The placebo effect is only related to the psychobiological phenomena, what is going on in the brain of the patient when you give a placebo. Well, today, in these 40 minutes, 35, 40 minutes or so, I will talk about the placebo effect only. You see here, for example, that I will focus my attention on expectation, the patient's expectation, what he or she expects when you give medical treatment, and learning. You will see that learning actually is very, very important, both from a neuroscientific point of view and from a practical point of view in the clinical, in routine clinical practice. So let me start with the definition of a drug. If we ask the question, what is a drug? Well, it is not very difficult to define a drug, because the most common definition of a drug is that a drug is a molecule, and you inject this molecule. Well, actually, you don't only inject, you introduce this molecule into the body, and this molecule can modulate the different biochemical pathways. Here, for example, you see the mu opioid pathway, COX, cyclooxygenase, and so forth. So this is the most common definition of a drug. It's very easy. It's not difficult. But if we change the question and if we ask what is a placebo, the definition is a bit more complex. The most common definition is that a placebo is a fake drug, or more in general, not only a fake drug, but more in general, a fake treatment, fake therapy. This is true. A placebo is a fake drug or a fake treatment, but something very, very important is missing. Because you inject or you introduce the drug or the placebo in a very complex psychosocial context. For example, the site of the hospital environment, the work by health professionals, the smell of drugs to be touched, by complex machines, for example. This is a very important psychosocial context that tells the patients now there is a therapy in progress, so you will improve in the next few minutes. This is this is a verbal or non-verbal communication between the doctor on the one hand and the patient on the other. So in a single sentence, we can call all these psychosocial contexts the ritual of the therapeutic act. In routine medical practice, there are so many therapeutic rituals. For example, the rituals of a shot, here the ritual of taking a pill, the ritual of alternative medicine, CAM therapies like acupuncture. Acupuncture has a very complex ritual, and this makes the patient expect a clinical improvement, or surgery. Surgery has a very important psychological impact on the patient. Psychotherapy as well, or different medical device, and why not shamanic? Usually I say shamanic rituals as well. It's up to you. I don't know. Fortunately or unfortunately, shamanic rituals may have, if you believe in shamanic rituals, may have a powerful psychological impact on the patients. Well, it's up to you. Fortunately, unfortunately. In my opinion, it's more unfortunately than fortunately. Well, anyway. Well, let me go back to the definition of drug, because all these rituals and all these psychosocial contexts around the patients, you can see here, can modulate the very same biochemical pathways that are modulated by the drugs we give in routine medical practice. Just to give you an anticipation, for example, the mu opioid receptors, if you give morphine or if you give a narcotic drug, morphine binds to the mu opioid receptors, but expectation about receiving morphine, the psychological component, may activate the very same mu opioid receptors. So drugs on the one hand and placebos or verbal suggestion or positive interactions between doctors and patients may use the very same biochemical mechanism, the very same biochemical pathways. So another point that is quite important is that usually people ask me, what is the mechanism of the placebo effect? This is the wrong question. The correct question would be, what are the mechanisms, the plural, across different medical conditions, across different therapeutic interventions. You see here that we know pretty lot about pain, about Parkinson's disease, some neuropsychiatric disorders like depression, anxiety, and some systems like the respiratory system, the cardiovascular system, and so forth. Of course, I have no time to discuss these medical conditions, so I will draw your attention only on pain. We know pretty much about the psychological and the biological mechanism in pain and analgesia. So, as I said before, there are many similarities between the action of drugs and the action of placebos. And I would like to start with the first example, the opioid system and endocannabinoid system. Well, you know that the opioid system, for example, some narcotics bind to the opioid receptors, but today we know that actually placebos may activate the very same opioid receptors. This is true for endocannabinoids as well. For example, tetrahydrocannabinol binds to the CB1 cannabinoid receptors, but today we know that actually placebos may activate the very same CB1 cannabinoid receptors. Just let me show you an example in a patient. This is a patient who underwent thoracic surgery for lung cancer. And this is the thoracotomy wound. You see, the surgical wound is pretty painful. So if you ask this patient to perform the full range of movement in this way, you see that actually there is a limitation of the range of movement. This is not surprising, of course, because the surgical wound is painful. Now we give this patient, this is a very good placebo responder. Not all patients respond like this one. This is a very good placebo responder. We give a placebo, which means we give a glass of fresh water, but we tell her that actually there is a powerful painkiller inside. And we ask these patients to repeat the very same movement. And now you can see that she can perform the full range of movement. So for a neuroscientist like me, the main question is what is going on in the brain of these patients? Why is there any analgesic effect? We did not give any drug. We did not inject any painkiller. We only injected words. How is it possible that words can induce an analgesic effect? So this is the patient seen from outside, which means, from outside, from the clinical point of view. Now I'm going to show you an average of different patients across different patients seen from inside their brain. This is a 3D reconstruction. This is an animation. You will see an activation, some orange regions in the brain, and in blue, deactivation and inhibition. So when we give a placebo, you see here that, first of all, there is an activation of different regions at the subcortical and cortical level. After a while, you see that all these regions are deactivated. These regions belong to what we call the pain neuromatrix, which is important for pain processing, you know? So if these regions important for pain processing are deactivated, well, it is not surprising that actually the perception of pain is reduced, and actually this is what happens. Well, this is an inhibitory system, and from a biochemical, pharmacological point of view, it can use at least 2 neurotransmitters. It can use at least 2 neuromodulators. It very much depends on the previous experience with drugs of the patient. For example, if there was a previous exposure to mu-opioid agonist, you know, when you give a placebo, a placebo is a sort of switch which turns on a memory mechanism for the activation of the very same mu-opioid receptors. So, I mean, there is a sort of memory for drug action. But if there was a previous exposure to CB1 cannabinoid agonist, you know, when you give a placebo is a sort of switch for a different memory mechanism, the activation of the CB1 cannabinoid receptors. Again, there is a sort of memory mechanism for the activation of two different classes of receptors. This learning mechanism, because after all, in this case here to the left, when you give morphine on Monday, morphine on Tuesday, morphine on Wednesday, morphine on Thursday, and then on Friday you replace morphine with a placebo, you know, a placebo can mimic the effect of morphine. And this is true for cannabinoid agonists as well. This learning mechanism is very important because it can be exploited in the setting of clinical trials, and it can be exploited in the routine clinical practice. Just let me show you an example. Indeed, it is possible to create placebo responders and no responders in the lab by using this conditioning mechanism. Drug, 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 and then you replace the drug with a placebo, you know? So, for example, it is possible to create placebo responders and no responders. Just let me show you an example here. It is not important what kind of pain this is. I mean, this is a pain tolerance, 15, 20, 25 minutes. On day one, this is the control condition, the baseline condition. You see that these subjects tolerate pain no more than 15 minutes. On day two, we give a placebo, and you see that the placebo given for the first time induces a small increase in pain tolerance. This is a small placebo analgesic effect, you know, an increase in pain tolerance. We can increase the placebo response by using a conditioning, a pharmacological conditioning procedure. You see here, on day one, this is the baseline condition. Again, tolerance is no longer than 15 minutes. On day two, we start matching what the subject expects and what he or she gets. For example, in this case, he expects analgesic effect and he gets an analgesic effect. On day three, again, he expects an analgesic effect, and actually he gets an analgesic effect. On day four, we replace the real drug with a placebo, and you can see that we can increase, compared to the placebo given for the first time, we can increase the placebo analgesic effect. But we can actually mismatch what subjects expect and what they get. Just let me show you here. Day one, this is the baseline condition again, and on day two, we start mismatching what they expect and what they get. On day two, they expect analgesia, but they get no effect. On day three, again, they expect analgesia, but they get no effect. There is a mismatch. When on day four, you replace the drug with the placebo, well, you can see that there is no placebo response. Well, actually, this is a way to create placebo responders, placebo non-responders in the lab. We want to create placebo responders in routine medical practice because we want to increase. For example, this could be you know, a clinical application to reduce drug intake, drug, then you replace the drug with a placebo, and then you go on, you give drug, then placebo again. In this case, you want to minimize the placebo effect. You want to block the placebo effect, not in routine medical practice, but in the setting of clinical trials. So in this case, you can create placebo non-responders, so you can increase the difference between the outcome induced by the real drug and the outcome induced by the placebo, you know. So cyclooxygenase, I mean, the story is not different because you know that non-steroid anti-inflammatory drugs inhibit cyclooxygenase, but today we know that placebos inhibit cyclooxygenase as well. Again, just a single example. This is the cyclooxygenase pathway. It is activated in hypoxia, headache. When you go to high altitude, for example, there is an activation of cyclooxygenase, and the activation of cyclooxygenase can produce vasodilation, and this vasodilation is responsible for the headache attack. So this is what happens from a biochemical point of view, and this is the biochemical profile during a headache attack. You can see that there is an increase in PGE2. PG means prostaglandin. PGE2, PGF2, PGI2. So when you give aspirin, for example, which is pretty effective in hypoxia-induced headache, you see that aspirin blocks the activation of PGE2, PGF2, PGI2, and there is a reduction of the headache attack. This is not surprising. But if you compare the effect of aspirin with the effect of a placebo, you see that actually when you give a placebo can reduce the activation of PGE2, PGF2 as well. You see here, the effect is much smaller. This is not surprising compared to aspirin, but you can see that the mechanism is pretty much the same. It's not different, and this is what happened from a clinical point of view: a reduction of the headache attack. So the nocebo effect. What about the nocebo effect? A nocebo effect goes in the opposite direction. This is the very same patient. She is a very good placebo responder, and she is a very good nocebo responder as well. We give the very same placebo, but along with the negative verbal suggestions. What we tell these patients, now I'm going to give you an hyperalgesic drug, so you have to expect an increase in your pain, but actually you give a glass of fresh water. So you ask these patients to repeat the very same movement, and now you can see that there is a further limitation of the range of movement. This is a sort of negative psychological effect. The surgical wound is more painful, and from a neuroscientific or neurobiological point of view, it is much easier to explain the nocebo effect, nocebo hyperalgesia, compared to nocebo. I'm sorry, placebo analgesia, placebo analgesic effect. What is the mechanism when you give a nocebo? When you give a nocebo, you induce negative expectations. You know, you induce negative expectations, and negative expectations induce the activation of anxiety mechanisms, particularly in the prefrontal cortex. And the prefrontal cortex, today we know that it can release CCK, which means cholecystokinin. It can release CCK and can activate cyclooxygenase. CCK, for example, has a facilitatory effect on pain transmission. So you see that the negative psychological effect, the nocebo effect, is very easy to explain. You induce negative expectation. Negative expectation induce an activation of the prefrontal lobes because they are related to anticipatory anxiety. You expect an increase in your pain, you know, and this can induce the activation, for example, of CCK, and CCK has a facilitatory effect on pain transmission. The hypothalamus pituitary adrenal axis is also involved in the nocebo effect, because for example, this is CRH, corticotropin releasing hormone, ACTH, and cortisol. This is nocebo challenge with fake oxygen. We tell these subjects that there will be some possible adverse events like headache, chest pain, abdominal pain, cough by breathing oxygen. They don't know that it is fake oxygen, of course. So you see here that those subjects reporting no adverse event, 0, those reporting 1 and 2 adverse events have no change in CRH, ACTH, and cortisol. But those subjects reporting 3 and 4 adverse events show an increase in CRH, ACTH, and cortisol. So the hypothalamus pituitary adrenal axis is also involved in the nocebo effect. Well, the last part of my talk, I think there are more or less 10 minutes left. The merging model has some clinical implication. Well, a first clinical implication I discussed very quickly. Unfortunately, I discussed some possible implication of the conditioning mechanism. Drug, then you replace the drug with a placebo. In the long run, you can reduce the intake of the drug. There is a second implication, which I think very, very important. This is the model emerging today. For example, some psychological factors, I mean, your interaction with your patient, when you give a placebo, when you induce positive expectations, can activate some molecules, and these molecules bind to the very same receptors to which the drugs we give routine medical practice bind. For example, you see here, the opioids, are activated endogenous, of course. Endogenous opioids are activated by positive verbal suggestions. They may activate the more pure receptors, but narcotic drugs activate the very same more pure receptors. So just imagine a situation, a routine medical practice, you give a narcotic drug. For example, you give morphine. Morphine binds to the more pure receptors, but expectation about receiving morphine can actually activate the very same more pure receptors. So there is a sort of interference between what you expect, what you get. What you expect is the psychological component, what you get is the pharmacological component. So my last question, I would like to answer the question, what is going on? I mean, what happens if we give a drug without the ritual of its administration? In this way, we eliminate the psychological factors, for example, the patient's expectation. And the question is the action of a drug the same without the patient's expectation, which means without the ritual of its administration? How can we do that? Well, this is a very long story. Just to make a long story short, I mean, this is routine medical practice. Routine medical practice, you see here, this is a doctor giving a painkiller. In routine medical practice, there is a very complex context, some intravenous lines, here some computers, The main element of the psychosocial context is the doctor herself, in this case, Well, the question is, what happens if we give the same drug, same dose, same infusion rate? I mean, nothing changes, but we give in this condition. This is what we call a hidden drug, hidden administration of a drug, a hidden injection of a drug. the crucial point here is that these patients do not expect anything because they don't know that the drug is being given, so they don't expect anything. They don't have expectations. They don't have the psychological component. Sometimes is so important, in the therapeutic outcome. So I would like to show you what happens when we give hidden drugs, hidden injection of drugs. This is a very long story, but just in a couple of minutes, in 2, 3, 5 minutes. Here you will see pain reduction here in 2 different conditions. An open injection according to routine medical practice, and a hidden injection is performed by a computer. Again, the crucial point here is that these patients do not know that any drug is being given, so they don't expect anything. This is what happens for buprenorphine, a narcotic drug. An open administration is more effective than a hidden administration given by a computer. This is true for other painkillers as well, like, for example, tramadol, ketorolac, and metamizole. You see here for metamizole, for example, a hidden injection performed by a computer is virtually ineffective. It is only effective when an open administration, when there is a good interaction between the doctor and her patient. So this is quite interesting from both a pharmacodynamic and a psychological point of view, because the real pharmacodynamic effect comes from the hidden administration, because the hidden administration is free of any psychological contamination, The real effect of the drug in this case is missing. This is only a psychological effect. And in the next example, this is and the last example. This is a trial. It is an animation because it is really impressive. The question of this trial is metamizole at this dose effective in this kind of post-operative pain, post-thymectomy pain? Well, you know that in the classical clinical trial approach, you have 2 groups of patients. One group would receive the real drug, for example, in this case, metamizole. The other group would receive a placebo. Then you compare the 2 groups, and if the outcome of the active treatment group is better than the placebo group, you say yes, this drug is effective. This approach is completely different. This is a new way of running clinical trial, because there is no placebo administration, but you can identify the placebo effect. How can you do that? You give an open administration of metamizole, in this case, according to routine medical practice, and in a different group, in a second group, you give a hidden injection of metamizole. There is a full informed consent, because this is what we tell these patients. You will receive metamizole, but actually you don't know when the computer delivers metamizole. So again, this is an animation because it is quite impressive. These trials last, you see here, more or less 6-7 hours. Here you will see the time course of pain, the progression of pain in the open injection, and here you will see the progression of pain perception in after a hidden administration. In this case, nobody knows when the computer is delivering metamizole. Here, the usual scale from 0 to 10, 0 no pain, 10 unbearable pain. And you see here, we start from a pain intensity of 5. This broken line represents the administration, the injection performed by a doctor, you see that after injection, there is an analgesic effect. Here, nothing happens, but somewhere here, the computer is delivering metamizole, you know. You see that there is a big difference, an analgesic effect here, no analgesic effect here in the hidden injection. So at the very end of the trial, we asked the computer, there is a code, we cracked the code, you know, and we asked the computer, when did you deliver metamizole? And this is the computer's response. The drug was given here after 3 hours. You see, there is no effect in this case. So what is this? I mean, this is a placebo effect, which is due to the doctor-patient interaction. So you can see that actually you can identify a placebo effect without giving a placebo. This is a new way. We are working a lot on this, a new way of running clinical trials. If the drug were really effective, in this case, metamizole is not effective. This is a psychological effect. It's not the effect of the drug. If the drug were really effective, well, we should see a pain analgesic effect in this case as well. I mean, not only in this case. So the placebo effect in this case is the difference between an open and a hidden injection. So at the very end of my talk, I think my time is up. This is what is emerging today. I had time to discuss only pain and analgesia, but this is a very general phenomenon. This is a general phenomenon, for example, in the immune system, in the endocrine system as well. In motor disorders like Parkinson's disease, we know pretty much about the mechanism, for example, in Parkinson's disease, in the cardiovascular system as well, and some neuropsychiatric disorders like depression, for example. This is what is emerging today. I mean, placebos, words, and therapeutic rituals, which means more or less the psychological component of any treatment, uses the very same biochemical pathways, the very same mechanism used by drugs we give in routine medical practice. This is the take-home message, because we can expect the different psychological factors can influence the effect of drugs, the response to a drug. So you see that we are beginning to understand something about the neurobiological mechanism of the placebo effect. Expectations are very important. Patients' expectations are very important. Learning is really very important. Pharmacological conditioning, for example. So let me thank at the very end of my talk all my collaborators in Italy and Switzerland, where I work, and thank you very much for listening.
Thank you so much. Thank you very much indeed, Fabrizio. Super talk. We've got a couple of questions, or one question. If anyone wants to ask a question that's on Zoom, use your chat. But we have one question from Dr. Damani, which is interesting. Does telling the patients that they might get side effects produce a nocebo effect?
Yes, it is possible. This is a very important ethical and methodological problem in the development of drugs, because you need to tell the patients, I mean, to tell the truth. You know, you have to, in the informed consent, there is a list of the side effects, and these can induce negative expectations. So this is a real problem. This is a big question, and it is not easy to answer. I mean, it is possible to overcome this problem, for example, by using authorized deception, what in the informed consent, the authorized deception or authorized omission. In the informed consent, you can omit something, for example, the side effect, because otherwise, you know, this can you can affect the therapeutic outcome. Of course, in the informed consent, the patients must sign the informed consent with an authorized omission. This is a big question, and very important. It is not very easy to answer and to figure out this problem.
Thank you very much. Yeah, that's Sanjeeva Gupta says, should we encourage to maximize the placebo effect in our patients?
Yes, we want actually we want to maximize the placebo effect in routine medical practice, but we want to minimize it in the clinical trial setting. We can do that. We can do that by using, as I said before, in a slide. You can create placebo responders and no responders in the lab. We want to create placebo responders because it is possible. I mean, to reduce drug intake if you use a paradigm like drug, and placebo. But if you go on, I mean, if you keep giving a placebo, there is an extinction of the effect. So you need a reinforcement. Drug, this would be the paradigm. Drug, placebo, then drug, placebo, and so forth. In this way, you can maximize the placebo effect. In the clinical trial setting, you want to do the opposite. I mean, to minimize the effect by mismatching, for example, what the patient expects and what they get.
Thank you. And Dr. Shelton asks, should we ever purposely use a placebo? That is, treatment which we know doesn't have an effect, but we try and sell it to the patient as.
Well, I am both a basic neurophysiologist and neurologist as well, and I have been working over the past few years to understand the placebo. But my take-home message is there are many take-home messages. My take-home message is don't use placebos in routine medical practice. You don't need to use placebos. Placebo effect is present when you give a real treatment. So when you give a real treatment, what you have to do to increase the placebo effect is to increase your empathic relationship with your patient. So you don't need to give a fake drug. You don't need to give fresh water. You don't need to give a placebo. You have to give a powerful drug, an effective drug, along with positive interaction, positive a relationship to boost expectations, the patient's expectation.
Thank you, Fabrizio.